Thank you for joining us for this EHE 360 Connect educational webinar. We're going to be talking about preparing for progress, genomic profiling to inform treatment, development, and care planning. So my name is Maggie, and I'm the Director of Development and Communications for the Foundation. Let's see, I want to remind all participants that the EHE Foundation does not provide medical advice. The information provided here is for your information only, and we encourage you to contact your own healthcare team for any specific questions about your health. I'm going to introduce Denise Robinson, our Executive Director, and she's going to talk a little bit more about what we're going to do today.
Hi, everybody. Thanks for joining EHE 360 today. We are so glad you're here, and we're glad to bring this session to you on genomic profiling. I believe this topic is important because as a community, you as patients should have as much information as possible about your disease, and clinicians increasingly will rely on this information for clinical trial enrollment and treatment decisions, care planning. So it's important that we work together to get treatments approved for EHE, and this is just one of the things in that part of our mission. So today we have the honor of having James Chen with us. He is a very busy individual. He's a medical oncologist specializing in the diagnosis and treatment of sarcomas at The Ohio State University James Cancer Center. He is also Senior Vice President for Medical Informatics at Tempus AI, and he's going to talk about genomic profiling, which is also called next generation sequencing, why it matters for people with EHE and sarcomas, and how it can inform clinical care and drug development. Welcome, Dr. Chen. Thanks for being with us today.
Thanks, Denise. Thanks, Maggie. And thanks for this opportunity to speak with everyone. Hopefully this is interactive, and I hope you guys have lots of questions. This is a topic that's near and dear to my heart. We've been doing genomic profiling since basically it began as soon as we could for sarcoma, and I want to share with you why and the what. So really quickly here, just quick disclosure, as Denise mentioned, I'm an employee at Tempus, but this talk today has no branding and is really me as an oncologist at Ohio State. And I just want to make sure that we have all the educational material that you guys need to make a good decision. So really quickly, I'm going to cover a couple things. And I'm going to talk a little bit about EHE basics, what exactly is molecular profiling, how to obtain profiling, and how you can get involved, and any questions that you might have at the end of this. So I've been practicing at Ohio State now for about 13 years in sarcoma. I have to say that molecular profiling really has started right when I started my practice. And this is now 13 years ago. It was, at this point, it was a little bit speculative. People weren't doing it all the time. Today, I have to tell you that I think it's very much standard of care for many types of cancers, particularly in sarcoma. So a little bit about EHE. So before we had molecular profiling, this is what people would see. They would look under a microscope, and this is a cross-section of a blood vessel. And if you look over here, this is kind of what we're looking at, kind of a blood vessel. You can see that here's the ring of muscular tissue that surrounds the blood vessel. And then you can see this big mass in the middle and mass over here too. What people realized was that there seemed to be a mass that was coming in from this inner layer called the endothelium. So you had a blood vessel, you had a mass or a tumor, and then you also had this, it seemed to be arising from the endothelium, and these cells looked endothelioid in nature. Okay, so that's a particular type of cell that one might see. So as a result, you have this large blood cells inside blood vessels growing from inside the lining, forming a tumor. And then that's how you got, and I totally stole this from the EHE 360 site. I love this. How you got the word epithelioid hemangioendothelioma, right? It's very, very descriptive. It's a really long name, but it was really being super descriptive of what people saw under the microscope. Now, why is this relevant? In modern days, we have a different sort of microscope, and I'll get to that. So when we think about EHE, I want you to, it's hard sometimes for patients and physicians and particularly people who are not within the medical field to understand how rare this disease is. So what I have here on the right is if you look at the green box, this is the new cases of cancer every year. And if you look at that smaller green box, that's all the new sarcoma cases, is about 1% of all adult cancers. Now, if you think about EHE belongs to a class called vascular tumors because it affects the blood vessel. That is about 1 to 2% of sarcomas. Now, when you think about EHE, these are very rough estimates. It's about 10 to 20% of sarcomas. I bet you can't see that little yellow box at the very, very, very bottom there. EHE is so rare that, your chances of getting it are basically being hit by lightning twice. So really has an ultra rare designation and is rare even among sarcomas. What does that mean for you practically as an EHE patient? It means that most pathologists, anybody who's come out of medical school, decide to go on pathologist, maybe has seen EHE once or only seen it in a textbook or really hasn't really had a chance to review those in depth. So finding EHE really requires reading the genome's fine print because it's so rare, we need other ways of also identifying it. The people in charge of the diagnosis are really your pathologists. But as I mentioned, most pathologists don't have the sarcoma training. So we really recommend that you see, and this is from the National Comprehensive Cancer Network. These are guidelines that come out on a regular basis, and they really form the backbone a lot of how we think about what are treatment options for different types of cancers. In January of 2025, you can see they really say that sarcoma diagnoses really need to be done by an experienced sarcoma pathologist. And they also mention that molecular genetic testing is often required as well to do confirmation or actually to help with the diagnosis. This is what is in our guidelines. Okay. So you might be asking, what does it mean to be an experienced sarcoma pathologist? Our pathologists who basically specialize in sarcoma get additional training to work in the sarcoma field, and oftentimes this is their primary role is to at large centers to look at sarcoma cases. And where do you find a large center? There's a lot of ways to do this. I tell my patients and also patient advocates to look for sarcoma centers of excellence. These are high volume sarcoma centers that have usually research and multidisciplinary folks, radiation oncologists, sarcoma surgeons, sarcoma medical oncologists, sarcoma radiologists. So these are sites around the country that have them. This figure I pulled from SARC. SARC has their own database, which is the sarctrials.org, sarcoma centers. Sarcoma Foundation of America also has a listing. You'll find other listings as well. But suffice it to say that you want your pathology specimen reviewed at a sarcoma center of excellence, or at least sent to a place that is a sarcoma center of excellence. Because for the very reason I mentioned, most pathologists will not have come across EHE unless they've done specific training or at a high volume sarcoma center where they see this with a little bit more regularity. Why does this matter? So we talked about what you can see under the microscope. That was the initial slides that I showed you there. And then I'm going to talk a little bit about, obviously, molecular profiling. Now, you must be saying, well, if looking under the microscope is so good, why do we need molecular profiling? The long and the short of it is that nothing is perfect, and diagnoses can change with molecular profiling. This is an article that was published back in 22, looking at several thousand sarcoma cases. And what you can see is on the left over here are the original diagnoses. And after molecular profiling, you can see that the diagnoses switched. In this study, these were switched about 11% of the time. At Ohio State, our number was about 15%. And in the Italian study, they also did a very similar study. They also saw about 15 to 30%, depending on where these came from. So this is a non-trivial, which means that you might have been diagnosed with one thing, but after molecular profiling, your diagnosis might change. this is important because your treatments also change based on what the new diagnosis looks like. All right. So hopefully I'm not going to bore you too much here, but I'm going to talk a little bit about genetics 101. This is the central dogma. You got Dr. Crick over there, who won the Nobel Prize for this. But you will really see that you have DNA, which is and everybody's seen this, CSI episodes. It's the stuff that basically is in your cells that tells how to make you as a person. Now, DNA is turned into RNA, which is a transport message, and that transport message then is carried to machinery, which makes protein. Right. So this is probably what you learned in biology class. These concepts are a little bit hard to understand, so I wanted to use this analogy instead, and this is from the biology primer that I really love this idea. So imagine your DNA is really information that's stored on a hard drive on your computer. Okay, so your hard drive is, let's say, several terabytes. It's huge, got a lot of photos, got a lot of everything else, but it has a lot of, in your case here, a lot of text documents. And one of the text documents has WWTR1, CAMTA1. This is your text document here. Let's say you wanted to print it out. So you just only wanted to print out this document. You're not going to print out your whole hard drive because that would be insane. You only want to print out this document. All right, so you hit print. What does your computer do? It has to turn it into a coded information that can be passed through the wire to your printer. This coded information as it's passing through the wire is your mRNA. That's that RNA, that's the message in transit, if you want to think about that. And finally, when it hits your printer, the ribosome, you can finally get a physical copy, the protein. Right? So for those of you in the know, you probably recognize these two genes, but I'll talk about those in a second. Now, let's pretend you had an accident. You dropped a cup of coffee on the keyboard and you accidentally hit the backspace key. What happened? Now you've lost the carriage return, and now you have this smushed together WWTR1 CAMTA1 document. It gets fed through the printer, and now the printer is printing out WWTR1 CAMTA1 as a single line, as opposed to being on two lines. Wow. All right. So this is not what you expected. And now this is what we would consider an alteration, right? Your initial document has altered. There's a couple ways you could have found where this altered. You could have tried to search your whole hard drive. And for any of you who have tried to search your whole hard drive, you know how difficult that can be to search your whole hard drive, looking for WWTR1 CAMTA1. The other way you can do it is you can try to look at all the sheets of paper that have been printed out and see if there's a WWTR1 CAMTA1 smushed together. Another way you can look at it is you can just try to look at all the messages that were sent to your printer, right? Sometimes if you go to your print settings, you can look at the queue and see everything that's been sent out. And this way too, you can see what has been sent to the printer and see if you have a WWTR1 CAMTA1. What I've described to you here are all the ways that you can do, some of the ways you can do genetic testing. So this WWTR1 CAMTA1 is what we call pathognomonic. What that means is that if we see it, it's super likely that you have an EHE sarcoma. The WWTR1 CAMTA1, these are two genes, and as you saw before, they got smushed together. I had it smushed together by a cup of coffee in the previous slide, but they can get smushed together because of errors in cell division. When the cell basically turns from 1 to 2, sometimes things get stuck together and the DNA creates a new gene, the zombie gene, WWTR1 CAMTA1, which doesn't exist in nature. This is about 90% of EHE cases. In less than 10%, there's another fusion, that YAP1-TFE3 fusion that exists. So fusion is not a direct mutation. It's basically this, what we call a structural alteration, when two genes come together and form this new structure which didn't really exist. Okay. And if you hear the word pathognomonic, that's what that means. It just means when we see it, we really think EHE. So when you do the genetic testing or this molecular testing, there's something else that you also learn is that you not only find the fusion, but you might find additional mutations. So in particular targeted genes, you might see things that are also broken. This is a paper that my lab published back in 2019. And what we showed here is that for CAMTA fusions, Canta EHE cases, about half of them had additional alterations that you could see. Here, one is called CDK and SWAY, that's fairly common. And in other papers, what that is shown as if you have an EHE mutation, EHE fusion, and you also have this P16, or sorry, CDK and SWAY mutation, these patients tend to have EHE that was more aggressive. So these secondary mutations really also provide color into knowing a little bit more about what the what variant or how the EHE might act. All right. So what are we testing? Okay. And so this question comes up. So we all inherit our DNA from our mother and father. So that's why basketball players, they've got tall parents, they can be potentially be tall. And EHE doesn't really occur like that. You want to think of this as that, you inherited your DNA from your mother and father, but let's imagine that you are in the sun the whole time and you never wear sunscreen. Okay, so we always think about skin cancer. That is the sun's rays directly affecting a part of your body, which is causing a mutation there. Did you lose or did your whole body's DNA change? No. You still have what you got from your mom and your dad. That's what we call the germline DNA. But the part of the skin that was exposed to radiation has changed. And so that's what we call somatic DNA change because it's just the body alone, it's not the whole body. And these can lead to cancer. These cannot be inherited. So EHE, as I showed you, is a structural variant. So when things came together, they formed this new fusion gene which didn't exist prior. You didn't inherit that because you would have been born with EHE as a result. Um, but it had come up what we think is sporadic, so this cannot be inherited. Now, that's not to say that you could have had inherited traits from your mom and dad that predispose you to cancer, that make it more likely that a cancer might form. But the EHE itself, if a patient does have that, it cannot be passed forward because you can't really, it, you, this is a fusion we do not believe that can be passed along. Okay, so also the people who are looking at these are a little bit different. When we think about germline or what you inherited from your mom and your dad, we're thinking about a genetic counselor. So any of you have gone through surrogacy or in vitro fertilization and had to get some genetic testing, they're testing the germline. They want to make sure that your child, whomever is inheriting from you and the person who's providing you the sperm or the egg, you don't have genes that are complementary that would cause cancer. Somatic testing is generally ordered by an oncologist and pathologist, and you need a tumor sample for that because obviously you need the area that was affected. One of the things I did want to point out is sometimes you do both types of sequencing. You often do what we call tumor normal paired sequencing. Why is that? The reason is because remember, you have a version of your DNA from your mom and your dad. And then when you get like that sun exposure or some sort of change, that changes the DNA in that local area. Just in that one area there, something gets messed up. So what's the best way of seeing what's messed up is to take what it was supposed to be and look at the changes from what is messed up. We do basically a subtraction. So this is probably the cleanest way to look at what has changed in the DNA, is this idea of sequencing both the germline or normal sequencing, as in this case here, and the tumor, and then you basically do this subtraction. All right. So wanted to point this out. Sometimes you'll see this on some of the molecular tests. This is what it means. It is just a cleaner way of identifying changes. I'm not going to go through this too in too much detail, but to suffice it to say that there are many things that can be tested. You can test blood, you can test the tumor, you can test single cells, you can test archival tissue. So these can be sitting around in a tumor storage bank for quite some time and still be tested and do well. If you think about DNA, we were able to test DNA from Egyptian mummies, right? So DNA is very stable, but different types of material, the RNA, and this is called circulating tumor DNA, which is found in the blood, the stability differs based on sample type. A lot of magic happens, a lot of very really cool science. If you ever want to have a super wonky discussion with me, happy to go through it with you. Um, Fusions fall into the structural variation category. But at the end of the day, what happens when we take all those samples, take the sample from you, take the sample from the tumor, put it all together, you get this molecular profile of what the tumor looks like. And then from there, we can make some guesses what some targeted treatments might be. So going back to this example here, I want to put that in context. So there are many places, as I said, that you can do this sequencing. You can look at the DNA, the hard drive, so scan the whole hard drive. You can scan all the messages that came through, or you can try to look at all the proteins, all the pieces of paper that have come out of the machine. This is a different view of that diagram. So DNA, RNA, and protein. Again, the central dogma there. Back in the day, and this is now going 20 years ago, 30 years ago, we only did single genes. We looked at PCR. Then we got a little bit smart about it, said, hey, we can probably do more than a couple genes. We did hotspot panels, but we did pieces of genes. Genes are very, very long. You can imagine that they're like they're not short little segments. They can be very, very long. And you're only able to sequence with PCR very small portions of that. And that's what we call hotspot panels. So you could do a whole bunch of genes, but you'd be sequencing little portions of the gene. These days, what we mostly do is a targeted next generation sequencing panel. So we'll take genes that we know are known cancer genes and we'll sequence the whole thing. Next up, which is coming down the pike, is something what we call whole exome sequencing. So if you think about the whole DNA, all of DNA, you have genes that make protein, and then you have spaces in between that don't make any protein. They have a function there. We're still learning about all the functions that they have, but you have genes, gaps, genes, gaps. Whole exome sequencing is just sequencing the gene portions of the program. And finally, the Holy Grail is really looking at everything, which is this idea of whole genome sequencing. So this is the same thing as looking through your whole hard drive. This is just looking through your Word documents, for example. Targeted NGS panels might be looking at a particular folder, and then hotspot panels might be even looking at something smaller. I'll go over why these matter in a second. Suffice it to say that whole genome sequencing today is prohibitively expensive. It's just a lot of work, and you're only looking for very specific things. PCR obviously is inadequate because you're only doing one gene at a time. So today in this day and age, we're looking at targeted NGS panels. For RNA, what I just talked about there, what we're able to do is actually look at the entire message that has come through that's been transmitted to the printer. This is what we call whole transcriptome sequencing. Okay. And then for protein, immunohistochemistry, which is a very traditional way of looking at proteins, does one protein at a time. We can try to do more with mass spectroscopy, but the technology there really isn't enough for us to look at everything, all the pieces of paper. What does this mean for you? It means that in modern molecular profiling, we're really looking at a large set of genes, a targeted NGS panel, and we're looking for whole transcriptome sequencing. Now, the reason why this is important because some places will say that you have done DNA, you've done molecular sequencing when they have only done either a hotspot panel or only done targeted next generation sequencing. They have not done whole transcriptome. Why does this matter? Here is a study from a Chinese sarcoma group, and what they showed was, see this left circle here? This left circle is looking at just DNA sequencing. This circle to the right is after if they've added RNA sequencing or fusion capture. What you can see is that when you add RNA additional testing, what you're getting are more fusions that can be seen, right? In this case here, they said 28% more. So for something like EHE, which is a fusion, which is rare, it may be missed, often missed, and it probably will be missed because the EHE genes typically are not on the DNA panel. You'll have to look for them on the transcriptomic level over here, right? So that's why you need both. Until we have this idea of whole genome sequencing, which is not today, we really rely on this transcriptome, looking at all the messages that were sent through to get us to find all the fusions that are detected. All right, so how do you get your tumor molecularly profiled? What does this look like? Well, first you need a piece of tumor, right? There's nothing to profile if there's no tumor. And then the physician orders the molecular testing. Typically, as I mentioned, this is an oncologist, pathologist. There's many ways where they can send this for testing. One is they can put an order through the electronic health record, the EHR, um, and this can tell the lab, be an internal lab or an external lab, that, hey, I would like DNA sequencing done or molecular profiling done. Sometimes in places that have less sophisticated systems, it'll still be on paper requisition, like kind of like a Sears catalog kind of situation, or it can be online ordering, like an Amazon situation, buying something that way, you'll send it through. And believe it or not, we still use fax machines. So some sites still are reliant on that. Obviously, we're trying to move toward EHR ordering, but not everybody's there yet. So don't be surprised that any of these ways are still being used. All right. So the order gets placed. The next thing that happens is that your pathology lab, the people who are holding on to have custody of the tumor specimen, needs to cut a piece of the tumor and send it to the lab of interest. This part can take a long time because, for example, for my patients, when I see a new patient, oftentimes the tumor specimen is not at Ohio State, it's elsewhere, right? And so we're asking another lab to either send us the specimen so we can cut a block and send it to and get it molecular tested, or we're asking them to cut a piece of tissue and send it to the lab for molecular testing. Typically, once the lab that's doing the molecular testing receives it, the turnaround time varies, but it's usually between 8 and 14 days, right? I often tell my patients it'll take about 3 weeks because I give a week for this portion to happen. But again, your experiences may vary. And finally, when the report is generated, then I am able to review it with my patient. So hopefully this looks fairly straightforward, but you can see that there are time components and dependencies. Sometimes when the lab receives the specimen, they realize that, gosh, the specimen that was cut was poor quality. And then we have to go back and get another specimen, which can add time to the whole process. All right. So what do these reports look like? And I'm showing you a super generic report. This is from the Journal of Molecular Diagnosis. This is from a couple of different pathology societies. They came up with this sample molecular report to show what they think a good molecular report might look like. I wanted to draw your attention to a couple different things on here. One is this idea of this molecular biomarkers result summary. So here are all the changes that people saw in the particular gene, in the particular alterations from the sequencing. And it's be it from RNA, be it from DNA, this is all put together here. If it were an EHE patient, you potentially would see a WW-Tier1-CAMTA1, and it would be called a gene fusion. And then if there were targeted therapies, it would be listed here. Now, I'm going to talk a little bit about secondary mutations for a second. So sometimes there's additional mutations that may have a targeted therapy, and they would be listed here. But it's important to also tell you that targeted therapies or therapies for that are matched with a particular alteration are not all built the same. There are different levels of evidence for how strong we believe the targeted therapy matches that alteration. There are cases where the FDA has said that this drug with is appropriate for this mutation and this type of tumor. That's kind of like the highest grade. The least highest grade is that we saw in mice that this drug appeared to affect this type of tumor. This would be more of a hypothetical level 4 type of indication. For sarcoma, oftentimes because there's not enough clinical trials, we'll say that this drug worked in a different type of tumor with the same molecular mutation, and we think it works in sarcoma. So it would be more of a grade 2, right? There's also the reverse. If we see a mutation, there are drugs that don't work. So we call these resistance mutations, and these have different grades. I'm showing you a grading system from OncoKB. This is out of Memorial Sloan Kettering. This is a set of grading in terms of house levels of evidence, but there are different levels of evidence rankings as well. So if you don't see this one, just be aware that there are additional ones that are out there that are all equally valid. All right, so another portion I want to point out to you is this section called variants of unknown significance. You often hear this called a VUS. So what's a VUS? All right, so just because something has changed doesn't mean that we know what it is. So oftentimes something has changed, and we're like, oh, this change happens all the time, it doesn't do anything. It's like my hair is black, somebody else's is blonde. Are any of these mutations? No, it just means that we have different colored hair. So it's benign, doesn't do anything. There's other cases where we see the change, like, uh-oh, wow, this will really cause cancer. This is pathogenic. So there's a lot of times where we see a mutation, we're like, well, we think this could be bad, but we're not sure. And it goes in this middle category called VUS. This is important for you to understand because VUSs are as good as the database at that time of annotation or adjudication of that mutation. What that means is that if I see you a gene mutation today or gene alteration today, and I say I don't know what it is, it doesn't mean that in 3 months I won't know what it is. I could very well have new data, and it could be put in the benign category, it could be put in pathogenic category. So this VUS category can change over time. So it's usually buried in the report, but it's an important part to just keep an eye on because it can move in either direction. And unless you're looking for it and actively updating yourself, you're not necessarily going to know whether or not it's become pathogenic because the report is static. And we'll touch on that in a second. This static nature of the report brings me to this part here. Know when your report was created because all your targeted therapies are the US are at the moment in time. So if the FDA comes up with a new drug that's really awesome for a particular mutation, a particular tumor, it won't show up on your paper because it was not in the database at the time of the report creation. So knowing this is very important. There's also the collection date, and I'm going to talk about that next. So not only does technology change, new drugs, new understanding of genes, but your tumor also changes over time. So here's an idea of a primary tumor. Might be the primary piece of EHE that could have been in the liver. Maybe there was a surgery, there's something left over, and now it's in the lungs. It's a metastatic site over here. You can see from this diagram that the cells look a little bit different because every step along the way, as they moved along, they changed. Also, if we treat the tumor, oftentimes they will develop drug resistance and the tumor itself will change. When I say change, what is actually changing? The DNA and the RNA and the protein of the tumors are actually changing. So when we do a molecular profiling, you're really looking at a snapshot in time at when the tumor was collected. If things change in your clinical situation, you can make an assumption that the DNA, the RNA, and the protein has changed within your tumor. So in order to get a fresh view of what has happened there, you probably need a new molecular test, right? You need to take another look at that. Using the old version will not be sufficient to see what has changed. I'm going to pause here for a second and just talk about kind of new developments that people will talk about, which is this idea of minimal residual disease testing or liquid biopsies. There has been, in recent developments for other types of tumors, this ability for us to track whether or not there's any tumor left over or any floating tumor cells in the blood through just through sequencing, looking for the tumor within the blood in a test tube. So you could just get serial blood draws to see if you can find any tumor in there. This works in a lot of different tumor types, doesn't work great in sarcoma. So unfortunately, we need better technology for what we consider this idea of minimal residual disease testing. We just don't have that quite yet. So right now, in my personal opinion, the only way to really assess the tumor over time is to really rebiopsy the tumor. All right. Denise had talked a little bit about clinical trials. So clinical trials are on this report really reflect the alterations. A lot of clinical trials say we're testing drug X, but you need to have mutation Y to qualify for the trial. So what does this mean? So if you don't have the mutation or the alteration in question, you can't qualify for the trial. So no mutation, no drug, no mutation, oftentimes no trial. Let's say that it does show trials, or you're getting this report a couple months later and you're saying, well, are there any trials that fit me? Where can you find them? I'm going to give a little bit of plug for the EHE website again. These are kind of a list of clinical trials. I know our friends at the foundation really try to keep this up to date. You can also look at places like clinicaltrials.gov. But I do encourage people to participate in clinical trials if they qualify for it. EHE is so rare. The only way we can learn about it is if people participate in trials and their experiences are captured. And so we know what works and what doesn't work to help the field as a whole. But for purposes of this, on the molecular report, you'll often see clinical trials listed. Keep in mind that's a snapshot in time. If you look at report 3 months later, the clinical trials have probably all changed. And I would encourage you to go to the EHE website or go to clinicaltrials.gov and see if there's any trials that make sense for you. All right. So, hey man, who pays for molecular profiling? You know, this is usually one of the first questions I get asked. Long story short, when I first started practicing with molecular profiling, it was very, very hard to get molecular testing because it was very expensive and it often wasn't covered. Today, it's standard of care for many types of tumors and situations. Usually in the metastatic setting, when advanced setting, insurance will automatically pay for it. At institutions that are very, very large, sometimes you'll have a large philanthropic program where they will do the molecular profiling as just part of their cancer program. For some people who don't have necessarily private insurance, or want to pay out of pocket, there is a self-pay rate, which is usually lower than what the rate that the pathology company, the labs, will charge insurance. Also, if you participate in a clinical trial, many clinical trials will actually do the profiling for you as part of the clinical trial. But again, not all of them do that. In this day and age, a lot of them expect you to have it already done. Now, if private insurance, Medicare, some of these are still not within reach, most pathology labs have patient assistance programs, which really take into account income and other determinants to try to adjust the rates appropriately or to try to help with copay. Okay, so in my mind, there's no reason why anyone should not get molecular profiling. You often hear doctors say you might hear people say it's like, oh, it's too expensive. Here are all the ways which you can get profiled. And if there are challenges, please definitely reach out to the foundation and because there's usually a path forward. And it's critical that you do get profiling for all the reasons I just mentioned earlier. Now, along with clinical trials, as I said, the only way we can learn more about the disease is to get information together. I'm going to plug the global registry here, the EHE Foundation has put together. The only way we're going to learn about, well, if you have this mutation, what happens? The only way we're going to do that is if we have enough patients to donate their data to a registry, put that all together, and just see what happens over time. So we have to link these molecular changes with patient outcomes to help find a cure. We need to know what works, right? So if we see this pattern, this molecular profile, this gene signature, right? You have the CAMP diffusion plus this, you do really well with this other medication, or you don't really need additional treatment. We can watch you over time, this sort of thing. So registries are very important, particularly for these ultra rare diseases. It really takes a community to empower researchers and empower the science to find new drugs. So big plug, very important. People ask me, well, how can I help out with the cause? Is it money? Yes, money is really important, but I think more importantly is data. Without data, we can't really do very much. All right, so kind of final thoughts here. I really want you to be your own molecular advocate. These tests, as I showed you, are very sophisticated and very costly. And are kind of like the culmination of a lot of molecular technology put together that we're bringing to bear for the clinical audience. So when you get these results, I want you to ask your doctor a couple of these questions. What do the results say? What do the tests say? And which results actually matter for my cancer? Remember, some of these are VUSs and we don't know what they do, so not all results are created equal. Is there anything that there is truly actionable? And if it's actionable, do these results change my treatment options? Sometimes actionable results doesn't mean that they're the best drugs to go on, right? So there might be a better drug that you're already on, and these just add additional color to the treatment options that you might have. Based on molecular tests that you have there, are there any clinical trials I should be looking at, right? So does this open up additional clinical trials? And as I mentioned, if you do this paired testing of tumor normal testing, this looking at your germline versus somatic and doing a subtraction, you will have information from your mom and your dad. EHE is generally not thought to be, again, inherited, but you could have factors, as I mentioned earlier, that could have been inherited. So sometimes they can arise, and that's something you should ask your provider. This answer oftentimes will be no. It should be no most of the time, but I've been surprised before, so I think it's worth asking. And then finally, what are the next steps based on this report? Should I get reprofiled in a couple months, or what does that look like? Or what are the action items? So these are things that you want to ask your physician to kind of go through with you when you get your molecular reports. So you really need to be your own best advocate. Keep in mind that no physician will know everything about all of this, and this because the field is moving so quickly. The drugs change every day. What we know about the genes change every day. The type of clinical trials change every day. There's a lot to go over. And with that, I will stop there and I will take any questions.
Thank you, Dr. Chen. That was great. You covered so many wonderful things, and I was sitting there going, I want to take a picture of that. I want to take a picture of that because you hit on a lot of really key things. I love the be your own molecular advocate. I think that's great. I wrote down that I'd never heard anyone say something about the chance of getting or having lightning strike twice as the comparison to the ultra rarity of this disease. But that's really impactful to hear that. And going to a specialist is really important because you want to have people that understand and know what to look for looking at this disease. So there are a couple of questions in the chat. We have a question that someone must have gotten a report perhaps, and it said there aren't enough sample to test. What are they testing? but I think you'll know what I'm talking about. Sometimes there's insufficient samples in order to do the assay and get an answer back.
Yeah. So oftentimes, if you think about it, um, if the EEG is in the lungs, and sometimes it does go there or it has started there, they'll put a small needle into the tumor, right? For this needle biopsy. You can imagine a needle biopsy. There's a tiny, tiny bit of tissue there. And if it's already been used a little bit for initial diagnosis, there might not be very much left over. But they'll send what they can, but that might not be enough tissue because you might have like a couple cells or a little bit there. And in those situations there, the options are to go back to the pathology lab to see if there's more tissue, or you might need a new biopsy. Unfortunately, that's just kind of a tissue quantity thing. Denise, just to kind of piggyback on that a little bit, there's also the idea of tissue quality. Sometimes if the tissue was not prepared well, the tissue could degrade over time. And in that case there, you might also have a not so much quantity of tissue insufficient is the quality is not sufficient enough for the genetic testing to move forward.
Gotcha. And we see that, Dr. Chen, with our biobank. If we have a specimen, it's a cord needle biopsy, there's not enough sample to share, if you will. All of that sample needs to be made available for the pathology and clinical care. So thanks for answering that. You put up a sample of the report, and someone asked, does everyone get a report like the one you displayed? This person said that they got a one-sentence report from Tempus, and I can't clarify if it was an exact one from Tempus or if it was a medical report generated by the hospital. But do most Tempus reports come back kind of like what you showed?
Yeah, the Tempest reports and most reports tend to be about 20 pages. Honestly, they're like 15 pages. They're very, very long. So the fact that you got a one sentence, it was probably a blurb that your physician might have provided for you. Um, the short answer is that the report has the molecular alterations, the changes that they see, and then they go into changes in detail. There's a section on clinical trials, there's usually a section on medications, there's a lot of sections, and there's also a section on the techniques that were used to even perform the assay. So the whole, if you look at a PDF, it's generally about 10 to 15 pages. They're long. They can be very, very long. And oftentimes, there are additional tests that will be added on to the initial testing. For example, you might be looking at, I'm not going to go into too much, but this idea of gene signatures or additional biomarkers that might be useful for your physician to understand your cancer a little bit better. So that makes the report even longer. It's cool, but I think it's highly unlikely that you have the whole report.
Okay, perfect.
Ask your physician to print out a copy for you and give it to you.
Yes, I think that's a great suggestion. Ask your physician for that original report, the full report, because it is yours. You should be able to have that, correct?
And that's what I usually do. I'll print out the report. We get an electronic copy. They're filed into our electronic health record, but we can also print out a PDF copy. And that's usually what I give to my patients as for their own personal record because it's theirs, right? It's always
Right.
going to be in my on the patient portal, so accessible. So, orders it's important to know, as I mentioned, the data time. And if you're not looking at it, who is, right? Your physician can help you, but you're going to be your own best advocate.
Yeah. I wanted to ask you, because we've talked about Tempus. You are an employee of Tempus. There are other platforms out there that do this, and some of them, and this just ties into another question where someone's asking, which type of testing did I have done? So different platforms, and I'm going to name a few, and you can chime in on this, but Foundation Medicine, Caris, there's there are a few more that you can name as well. The reports are all, in my mind, they're quite long, as you said. You feel like you need a PhD in order to understand the report, but you almost always, I recall, you can tell what assay or what panel has been run or used when you get that report back, even if IHC was done at the institution, you would get that back. Is that correct?
Yeah. So on the report itself, as you saw on my sample report that I showed you there, they do call out if it's DNA, if it's RNA, and they will call out if they saw a fusion. What you need to know is what test was actually run. Did they only run DNA, or was there an RNA component as well? And that usually you can see that on the report because you can look for the word RNA, right? If it's not there, unlikely that or the word transcriptome, it's unlikely that it was run. You can also ask your physician what they order because, it's not like these reports get automatically run. Somebody literally had to request that this be run and tell the pathology lab what test they wanted run.
Mm-hmm. Okay, perfect. Let me just check really quickly. I've got more questions. I needed to scroll real quickly. How would different mutation types vary or be treated differently? That was a question regarding treatment, and I'm not sure if you want to answer that one or just give a short answer on that.
I think the short answer is we're learning for EHE. We do know that some genes, as I mentioned, at least not from a treatment standpoint, but more from a how aggressive the disease looks like, more from a natural history perspective, are useful prognostically, but whether or not you can use it to predict what drugs, we're not there yet.
Great, thank you. We have someone who's asking can ascites as well as tumor tissue, so serosal fluids, pleural fluid, ascites fluid, can those be tested as well?
Absolutely. So we do that pretty regularly. The key thing is there with the ascites fluid, you need to have enough cells because you're testing, looking for the cells. So not all ascites fluid is created equal, just like everything else. Some ascites fluid is really purely fluid and no cells. You need enough cancer cells in there for us to be able to extract the DNA from the cancer cells. So that's a question. That's something you're going to need to talk to your physician about because they have a report that tells you if there's cells in there. You need enough cells for them to do that.
Yeah, and we know also again from our biobanking experience that varies quite a lot with patients on how much cellularity there is in those samples. There's another question: how long does a major center maintain tissue? Can it be studied later? And so, I guess first of all, how long would institutions usually keep archived tissue?
I think by law, and don't quote me on this, I'm not a pathologist. I believe it's 10 years. I think it's what's by law. Now, what they do institution to institution after that, I'm not quite sure.
Okay, perfect. And I believe you mentioned this earlier. It can be assayed anytime later, really. Correct?
Yeah,
Depending upon the sample type, obviously.
Yeah, so a long time ago, that's a long time ago, 13 years ago, it had to be like the tissue had to be fairly fresh for what it's worth. These days, technology has gotten much better, and we're able to use older archival tissue pretty regularly without any problems.
Yeah, okay. I think, Maggie, chime in if you see anything that I've missed, but I think that we have hit the major questions. This was great. Again, really good information, and I love how you, I had not seen the printer analogy, but I love that. Super simple, because these are complex topics, and I really think that this is something that this community and patients can do to help inform, if not their care today, for finding targetable mutations. But let's get ready because we know that there are more clinical trials coming for EHE. There are more clinical trials today than we've ever seen for EHE patients. And we can only expect that number is going to grow next year and beyond. So I think that this is a get ready.
Yeah, and absolutely. I think one of the key things to remember is that EHE is not just a pathologic diagnosis, it's a molecular diagnosis. And so I think it's actually underdiagnosed because people aren't doing the genetic testing for it. I think if we did more of it, I think we'd see it a little bit more often, and that would actually help with the registry, help with trials, et cetera. So just keep this in mind. This is something, again, I think is going to be standard of care or is standard of care for sarcoma treatment. And anything that we can do as a community to move that forward, I think is very important.
Thank you very much. This has been great. We really appreciate your being here today. And for everybody, if you have additional questions, if this conversation generated more questions than we've answered, if you'll shoot an email over to info@FightEHE, we'll come back to you with answers to those questions. If not through Dr. Chen, then through our medical team, our advisors. So we're glad to help as best we can. Be your own advocate. This session has been recorded, so the session will be posted in the coming couple of weeks. I'm not going to promise a timeline, and it is the holidays, but the session will be out so that you can rewatch it later and come back and look through things that you might have wanted to revisit. So thank you. Thank you, Dr.
Absolutely.
Chen.
Thanks for the opportunity. And
we really appreciate it.
Yeah, and happy to help out if anybody has additional questions.
Thank you. Thank you so much. Be well.
Take care.
Take care, everybody. Bye-bye.